Good morning. Thank you to the organizers, Drs. Delay, Israeli, and Dr. Hu, for inviting me to participate. It's always an honor. I'm going to be going over some of the key abstracts from this year's DDW. Dr. Lembo and I kind of split these up to cover some of the main highlights. Obviously, we can't cover everything, but we wanted to emphasize some of the notable work that was done and presented this year. And the abstracts that I'll be presenting, few of them focus quite a bit on pathophysiology, and then a couple of abstracts that talk about treatments and novel approaches to treating these common but challenging conditions. So the first abstract I wanted to talk about is this abstract that came out of Belgium, and it was entitled Duodenal T-Cell Profile Predicts Response to High-Dose PPIs in Functional Dyspepsia. So functional dyspepsia, we're all very familiar with it, very common disorder, but the pathophysiology is pretty poorly understood. The duodenal mucosal immunological environment has been implicated through studies involving histological work as well as studies using flow cytometry. But PPIs, even though we use them as first line, their potential anti-inflammatory effects are often rarely considered. So well-designed studies that explore the effects of PPIs as well as their possible immunomodulatory mechanisms could be very informative. So in this study, the researchers from Belgium, their aim was to study the mucosal lymphocyte populations in the duodenum of patients with functional dyspepsia, and they also aimed to evaluate local immunomodulatory effects. This was the general study overview. They had patients with functional dyspepsia and healthy controls, and they recruited them for upper endoscopy. And at baseline, they took duodenal biopsies from all participants. And then in patients with functional dyspepsia, they repeated the EGDs with biopsies after 4 weeks of high-dose PPI. They then used the PAGI-SIM questionnaire to assess the symptoms, and they isolated duodenal lamina propria cells, stained them, and acquired them using flow cytometry. So in total, they recruited 28 participants with functional dyspepsia and 30 healthy controls. As expected, the symptoms were higher in the functional dyspepsia group. And when they looked at the biopsies, they actually saw that the cytotoxic T cells were increased in patients who had functional dyspepsia. And then when they were treated with the PPI, the cytotoxic T cells actually decreased. They did find higher baseline tryptase at baseline as well, but this was actually unchanged after PPI therapy, and baseline tryptase can be a marker of the innate immune system. And when they correlated the T cells with the tryptase, they actually found a significant relationship, and this suggests that perhaps the innate and the adaptive immune system are activating together in functional dyspepsia. They also looked at clinical response to PPI therapy. About 54% were clinical responders, and their baseline symptom scores were actually similar to the non-responders. But when they looked at the biopsy results, they noticed some differences. So naive T helper cells were lower in the clinical responder group compared to the non-responder group, while other T cells, including effector memory T cells, were higher in the clinical responder group. And then in addition to that, in the responder group, but not the non-responder group, improvement in symptoms after PPI actually correlated with a decrease in a specific subset of these effector memory cells, and that's shown here in the bottom panel of the figure. So in conclusion from this abstract, through their work, the authors showed that there does seem to be evidence for duodenal immunological alterations in functional dyspepsia and possibly a role for these Th17 effector memory cells. And altered effector memory TH cell populations seem to even differ between various functional dyspepsia subtypes like postprandial distress syndrome or epigastric pain syndrome. They observed a decrease in Th17 effector memory cells, and that this decrease was associated with symptom responses. And so based on this work, it suggested that further research looking into the possible anti-inflammatory effects of PPI may be warranted, or possibly something that you can discuss with patients as well if they're questioning what is the role of PPI in treating my symptoms. And then could also even suggest that there might be opportunities for targeting Th17 as a novel therapy for functional dyspepsia moving forward. Here are some of the strengths and limitations that I like to think about with these abstracts. This is a prospectively enrolled cohort. They looked at symptoms and immunological profiles. They didn't really have data on diet, which may be important, and they didn't have histology either, but nevertheless, I think very interesting work. All right, so we'll move on to this next abstract, disaccharidase deficiency in adults with IBS and functional diarrhea. This came from collaborators at Michigan and University of Texas. So patients with disaccharidase deficiencies can actually suffer from many symptoms that overlap with common DGBIs. But the prevalence of disaccharidase deficiencies in the United States is not well defined. And I think many people may have heard about sucrase isomaltase deficiency, which has been implicated in IBS. So in this study, the investigators wanted to assess the prevalence of disaccharidase deficiency in patients who had IBS with diarrhea and functional diarrhea. They recruited adults across several academic medical centers, and they had these participants complete upper endoscopy with small bowel biopsies, and they went to measure disaccharidase activity, and they also had participants complete sucrose breath testing. They had a total of 199 patients, and more than a third of them had at least one deficiency, with lactase being the most common. And the other types of deficiencies were less common. You can see that here in the table. When lactase deficiency occurred, it usually occurred in isolation. And in those who had a non-lactase deficiency, most people had multiple deficiencies. About 30% had a positive breath test, and they looked at the performance characteristics of the breath test based on the and they used the biopsies or the disaccharidase activity as a gold standard. And as you can see, the performance characteristics of the breath test are shown in the table, and generally it exhibited pretty low sensitivity and only moderate specificity. So in conclusion, they found about a third of adults who had IBS-D or functional diarrhea had at least one deficiency. Lactase deficiency is the most common. Non-lactase deficiency occurred in about 10% of patients and usually associated with other types of deficiencies. Unfortunately, in this study, the breath test demonstrated limited predictive value, but based on the findings, the authors again demonstrate that there is evidence suggesting that we shouldn't overlook the possibility of disaccharidase deficiency in patients who have these common symptoms. Some strengths and limitations, I won't go over them in too much detail, but I did like the fact that this was a very large sample size. They had paired biopsies and breath test results. There is, unfortunately, we still don't have data on a control cohort, so we don't really know what the baseline prevalence is. And there is a possibility of sampling error even with biopsies because there can be patchy distribution of disaccharadases. Okay, so this is another abstract that came from the CEDARS group entitled Hydrogen Sulfide Producers in the Duodenum by Shotgun Sequencing Correlate with Hydrogen Sulfide Levels in Breath Testing. And I thought that this was interesting because this is, again, an area of emerging research. Hydrogen sulfide is a gas produced by bacteria in the GI tract. And there is a new breath test available that can measure hydrogen sulfide along with other gases. And some studies have suggested higher rates of hydrogen sulfide production in patients with IBS-D. So the aim of this study was to examine the duodenal microbiome in patients undergoing breath test and determine if hydrogen sulfide levels correlated with these hydrogen sulfide producing microbes. So they had adults undergoing EGD and recruited them for collection of duodenal aspirates, and they also conducted breath testing. They took the aspirate samples and processed them for shotgun metagenomic sequencing. They were able to obtain aspirates from about 109 participants, and what they found through their work was that the relative abundances of certain hydrogen sulfide producers were associated with breath test results, and in fact there were certain taxa, so abundances of desfulvibrio desulfuricans correlated with hydrogen sulfide levels, and then there were abundances of 5 other species belonging to groups, as I've shown here below, that also correlated with hydrogen sulfide. Proteus mirabilis, which is also a hydrogen sulfide producer, correlated with hydrogen sulfide on breath testing, and they found that the more of these species that you tended to have, the higher hydrogen sulfide levels these patients demonstrated. There were also 3 microbes shown here in the bars that were particularly associated with hydrogen sulfide increases. And if you had all 3 of these led to a substantial rise. In addition to this, they conducted some functional pathway analysis using their metagenomic data, and they also demonstrated that there seemed to be elevations in pathways that were related to hydrogen sulfide production. So in conclusion, through this work, the authors showed that the duodenum does appear to contain hydrogen sulfide producing bacteria. The relative abundances of these species and the number of different producers do appear to be associated with breath test results, and there were 3 major bacteria that seemed to account for this association. So even though, again, this is very preliminary work, there is questions remaining about understanding the role of hydrogen sulfide producers, their location in the GI tract, and how this might be relevant for future microbiome-based works. So a very sizable cohort, again, concomitant analysis of small bowel samples and breath tests, and there is biological plausibility here. There are some limitations, so this was a cross-sectional analysis, and they didn't assess transit, which can affect breath testing results. And the small intestinal microbiome is often very challenging to study and can be prone to biases due to its low abundant nature and the fact that the small intestinal microbiome is very dynamic. All right, we'll go on to this abstract. This was presented at the plenary session for NGM. I thought this was interesting, very timely topic entitled Constipation in a large online cohort of persons with Parkinson's disease. So constipation, very common symptom among individuals with Parkinson's disease. We're recognizing this now, and it can actually precede motor symptoms by up to 20 years or more. But the relationship between constipation and other non-motor symptoms and motor symptoms in Parkinson's disease is fairly unclear. So in this study, the authors aimed to evaluate the relationship between constipation and other symptoms at baseline and over time. They used participants in the Michael J. Fox Foundation, which is an online survey of almost 40,000 patients with a physician diagnosis of Parkinson's disease. And of this cohort, over 30,000 have reported whether or not they've experienced constipation. And what the authors analyzed was the relationship between constipation and things like daily activities, quality of life, comorbidities, depression, and then as daily activities at baseline, as well as the development of new non-motor symptoms over time. They had about almost 4,000 patients who did not have constipation and over 16,000 patients who did report constipation. Among the Parkinson's disease cohort, those who had constipation tended to be older. They were less, they tended to have Parkinson's disease of a longer duration, higher comorbidities, worse depression, greater impairment. And when they analyzed the associations, they found that an increase in the severity of motor symptoms at baseline was associated with constipation that's shown here on the left. And over time for the whole group, there was a small increase in the severity of motor symptoms over time. When they looked at baseline, there were only certain non-motor symptoms, specifically talking during sleep, that was actually associated with constipation. But then at follow-up, the risk of developing new non-motor symptoms was enhanced in the Parkinson's disease patients who had the constipation. And some of these specific symptoms included things like anosmia, dysphagia, urinary problems, falls, and talking in sleep. In conclusion, what they found here was that about 82% of the cohort had constipation, so that's the vast majority. Constipation was associated with more severe motor and non-motor symptoms, as well as poor quality of life, and it was associated with a greater risk of developing non-motor symptoms over time. So there is a strong imperative to conduct further prospective studies, confirm these findings, and also understand the mechanisms that explain the differences between patients who may suffer from constipation and patients who don't. Strengths and limitations, I won't go over those in detail, but I wanted to put that up here on the slides. These will be available for you as well. Okay, so the last two abstracts, these were not actually oral presentations, but they were posters of distinction, and I thought that they were really interesting and probably relevant for clinical practice. This first one is an abstract entitled Clinical and Manometric Outcomes of Biofeedback for Refractory Constipation Due to Outlet Dysfunction. First author is Giuseppe Chiaroni. So functional defecation disorders, we're all pretty familiar with them. They're a common cause of refractory functional constipation. And anal rectal manometry and balloon expulsion tests are usually suggested in patients who have refractory symptoms. And even though biofeedback is recommended as a treatment of choice for dyssynergia, we don't really know how effective it is in other types of evacuation disorders. And we don't know if the presence of conditions like irritable bowel syndrome impact biofeedback outcomes. So the goal of this study was to evaluate clinical and manometric outcomes of biofeedback in patients who had refractory constipation, regardless of the type of functional defecation disorder they had, or regardless of whether or not they had comorbid IBS. They recruited 131 patients with refractory constipation who had defined and had evidence of a failed balloon expulsion test. And all participants had baseline testing, and then they underwent biofeedback therapy by a therapist who was blinded to their baseline test results. They had their symptoms assessed 30 days after treatment, and primary responders had to exhibit an improvement in both their complete spontaneous bowel movements as well as high score on their defecation quality questionnaire. So here's what they found. They had 102 patients who had functional defecation disorders. Most of these had either inadequate propulsion or dyssynergia, and there were about 27 who had a structural outlet dysfunction. Sex, age, and IBS-C didn't affect outcomes, but after treatment, there was improvement in their symptoms as well as in their defecation parameters, particularly in those who had either dyssynergia or inadequate propulsion. And by the end of treatment, 82 actually had a normalized or negative balloon expulsion test, and all the anorectal manometric parameters improved. At the top here, the top table, they showed that rectal sensory testing differed between people who were actually responders versus non-responders. And they showed that people who improved on anal rectal manometry also had improvements in clinical response as well. What they didn't see, however, was any improvement in patients who had structural outlet dysfunction, which is probably expected. So the conclusion here is that biofeedback is the treatment of choice for any functional defecation disorder, regardless of etiology. It could be dyssynergia, it could be inadequate propulsion. Symptoms due to structural disorders don't respond, unfortunately. And comorbid IBS-C doesn't seem to negatively impact outcomes. But these findings suggest that we should be referring our patients early, despite the Rome-3 or Rome-4 subtype of bowel dysfunction they may have. Okay, so again, some strengths and limitations, I'll include that here. Prospective study, they did have a therapist who was blinded, and they did use a pretty rigorous endpoint. There was no control arm, however, and they didn't report baseline severity of symptoms, which may impact outcomes as well. Okay, so the last abstract I want to cover was also a poster of distinction, but I thought that this was relevant for practice because it's very applicable for a challenging condition, functional abdominal bloating. This was a pilot study using an app-based hypnosis and diaphragmatic breathing intervention. Functional abdominal bloating is very difficult to treat. I think we're all pretty familiar with that as well. It's a predominant symptom in many disorders of gut-brain interaction. And as far as we know, many patients suffer from abdominophrenic dyssynergia. Hypnotherapy and diaphragmatic treatment or diaphragmatic breathing have separately been shown to be effective, but haven't classically been combined together under one united therapy. So the aim of this study was to obtain pilot data on the therapeutic impact of a novel audio-recorded bloating treatment that integrates hypnosis and diaphragmatic breathing. They had patients who had non-organic bowel disorders but had predominant bloating symptoms complete a 7-session audio-recorded therapy program using a smartphone, and this occurred over the course of 12 weeks, and there was no clinician involvement. And they targeted bloating through hypnotic suggestions, imagery, and guided diaphragmatic breathing, along with self-guided breathing exercises. And they assessed patient outcomes at baseline, mid-treatment, end of treatment, using a variety of questionnaires, which I've included in this slide. It was a fairly small study, but they had almost all participants complete, 22 out of 23. And what they showed here, you can see on the figure, is that at the end of treatment, they had significant decreases in the IBS-SSS bloating severity, as well as in the PAGI-SIM bloating severity. 70% actually met the endpoint for treatment responders, and 74% had evidence of response to overall bloating symptom severity. And this effect was maintained at the 3-month time point as well. They also looked at VSI for bloating-related anxiety, and they found that this endpoint was also improved at treatment and at the 3-month follow-up. There was no significant change, however, in anxiety, depression, or quality of life, no adverse events, and almost all the participants reported satisfaction. So in conclusion, these findings suggest there is therapeutic utility of self-administered bloating intervention. Treatment may influence bloating, overall GI symptoms, and GI symptom-specific anxiety, and the effect appears to be durable. Further larger randomized control trials are required, and I believe the authors have that currently planned. And then just to finish up some strengths and limitations of the study, this is the first study to examine the combined effect of hypnotherapy and diaphragmatic breathing together. They had very little loss to follow-up, and they had a pretty robust statistical framework. And they used a number of validated tools. It was an unblinded study from the patient perspective and single arm, again, pilot study, and they didn't actually assess how adherent the participants were to each aspect of the protocol, but again, very promising. And I think some of these questions will be answered with the RCT.